Thanks for the wonderful opportunity. I think it is a real pleasure to join the team, and it is thanks for the opportunity. I think I have to say with the introduction what I've been hearing. I don't want to do any further do in the about explaining the program and the importance of it. So my duty for next 20 minutes or so is to convince you how important the preconception endocrine care is. It is a huge topic, but I try to make it possible in 20 minutes or so. Um, can you make me to? I can't move the slides. Okay, that's fine.
Can you check out?
So yeah, so I'll just go through this the contents, and what I will do is so as Madam Prema Madam is saying, there is a huge challenge in pregnancy with the potential impact on pregnancy when you don't treat the endocrine disease properly. But mother and fetus, there is a constant change happens, and there, as Madam said about the maternal and fetal placental unit that works as an endocrine organ, and it's a temporary organ, but we have to consider all that about the feedback changes. And initial phase, the fetus is totally dependent on the mother, but later I think the fetus glands take over. So these are the things that we should know as a basic principles. And another challenge is, can you mute everyone, please, if you don't mind? To continue the treatment of the endocrine disorder, which is pre-existing, or whether it is a new diagnosis, Madam was mentioning. So if there is a new disease that has happened, and that needs to be taken care in a different way. So as preconception care goes, it is a process of identifying social, behavioral, environmental, and biomedical risk of a fertile woman, and just discuss about the pregnancy outcomes, and thereby have a goal and reducing by education, counseling, and appropriate intervention in the right time during the prenatal time. So as I mentioned that if you don't do the prenatal care properly, there is a poor maternal and child health will be the consequence, and it is important to do that for a short and long term. So counseling will be one of the mainstay of treatment. But endocrine disorders in pregnancy, why is it is important? Because it can lead to maternal and fetal complications, and it has to be treated properly. And there are a lot of changes, the baseline changes in the pregnancy that happens. We have to understand that, and then the initial period of the pregnancy as well, that during the hyperemesis and everything, there are a lot of changes happens in thyroid function and other things, but that also need to be taken into consideration. So if you go back, can I stop here? I think I got another presentation. I got so yeah, that's the one. Sorry about this. So why is it important, the endocrine disease? I've just briefly mentioned about it. There are a lot of changes happens physiologically, and hyperemesis is one of the condition that has to make a lot of changes in thyroid function and other endocrine disease that has to be taken into consideration as well. So I'll go through first diabetes in pregnancy with the common things. I'll go through first. This is a case scenario of a 33-year-old walking into OBG department, and it's type 2 for past 2 years. Metformin and gliptin was there. A1C was 7.9, and you got fasting and PP high. What is the recommended line of management for her, or how do you get this pregnancy going? Now, the diabetes and preconception care, the main principles are going to be patient education, glycemic control, and also the proficient diabetes self-care, which is very important. And
Suresh,
also
sorry to interrupt, but I cannot see the slides.
Sorry?
We're not able to see. We cannot see your slides.
Oh my God. Okay. And show. Okay. Can you see it now?
Yeah, but you'll have to put it in slide mode. I think you'll have to put it in slide mode, Suresh.
Can you see it?
Yeah, we can see it. Thank you.
Sorry about that.
No.
So the A1C is 7.9, and this is the typical scenario that we'll face up with a 33-year-old coming into the department with a pre-existing disease of type 2. Now, diabetes and preconception care, the key components of the management is going to be patient education, glycemic control, and the diabetes self-care, which is also very important, and also dealing with medical optimization. So these are the factors that needs to be considered with the pre-existing disease. So multidisciplinary team is needed, of course, and endocrinologist, obstetrician, and the active member in the team will be the patient, is the main team member. God, what is that? So the patient education is going to be the key, and diabetes self-management skills has to be explained, and regular follow-up is needed for all these patients. So so the risks of counseling, we have to explain for the type 1 and type 2, both of them, obstetric complications, fetal, and also maternal risk. I won't go into the details, but I think the type 1, the way of counseling should be slightly much more involved and everything, because you might have a mother who's experienced with a disease, and there are a lot of challenges they went through as a teenager and the early part of adulthood. So we have to deal it separately compared to they would be taking much more easily, and we have to convince in a better way. And when the A1C risk is A1C, the risk goes up, we have to explain to the patient. So the preconception evaluation management, the key thing will be a glycemic control, which has to be very, very tight. A1C has to be very tight as well. And then the insulin therapy, you have to discuss with the patient. Most of my patients I discuss very early itself, so they get more convinced that there may be a possibility of going into insulin. If they're on oral drugs, they change into this thing. If the metformin is the one drug, that then goes into the next drug requirement. But management of hypo, diet, weight, exercise, folic acid supplementation, and blood pressure and lipid control, these are the things that normally has to be done. But the challenge is, if they are on statin and other drugs, then you have to stop most of the drugs for completion of pregnancy. So diet, exercise, and avoidance of stress and regular monitoring, all this has to come in the counseling. And we have to talk about what sort of insulin is going to go in. Mostly basal insulin and OADs are not recommended apart from metformin. All this has to be discussed. And something called RLP, which is a reproductive life plan, which is like in next 2 years, if you're planning, what are the things that is whether recommended multivitamin and other things. But if they are planning to conceive within next 2 years, then encourage the reproductive life plan, vitamins, assess the risk. And as I mentioned the previous few slides, we have to go through most of them and explain to them diabetes is a serious thing that can affect the mother and child in a big way. Coming to the other common disorder, which is a thyroid disorder in pregnancy, again, a scenario of a 30-year-old with a hyperthyroidism on methimazole, wanting a successful pregnancy. How do you counsel them? What are the things that will be need to be discussed with them? And if you look at the thyroid axis, I won't go into the details of it, but it's controlled from hypothalamus, pituitary, and then the feto-maternal unit. As a mother, as Madam said earlier, there will be a lot of changes with HCG. In the first trimester will lead to low TSH, and then the TSH return to normal throughout the rest of the pregnancy. That has to be just considered, and sometimes you have to explain to the patients in detail, so they'll get more anxious after seeing the results of the early pregnancy. And then estrogen also does a lot of changes that also need to be explained if you the patient is asking, because that sets up anxiety to them. And for a patient who are not thyroid disease before, universal, it is not recommended. But however, practically in India, a lot of people do it, and gynecologists do it without doubt for everyone, most of them, which is probably a right way to do with the thyroid function being not that much expensive. And women who really benefit from screening is the high risk ones. But I think this is just to summarize how you diagnose a hypo or a subclinical hypo or a hyperthyroidism. It is just a basic thing. But once you diagnose, you find out that is subclinical hypo is the one of the condition that needs to be weighed properly, whether that needs treatment or not. That has to be decided on the basis of antibodies and family history and the risk of the pregnancy and other autoimmune disease. Whatever it is there, you correlate everything and then convince the patient that you might need treatment going into the pregnancy. So how do you do for hypothyroidism treatment? You start on levothyroxine, make sure that the TSH is adequately replaced and adequately done before planning for going into the pregnancy, because you explain them about the intellectual development, and then most of them will say yes to the treatment. So again, just to say, if it is a overt hypothyroidism, there is no question about it, and you can explain the complications and how do you manage just to monitor AFT4 and TSH and adjust the dose to make sure the TSH gets below 2.5. And then the conception advice, you can just to make sure that the counseling is done appropriately for them. So how about hyperthyroidism? Hyperthyroidism, you can also say what are the drugs that we will be using and what are the challenges and what are the complications that might happen as a preconception care. But you need to explain most of them. You don't need to go into the detail, but I think you tell it is a risk and we'll do as a teamwork, and that normally puts them less anxious, because they might be over anxious because of their already affected hyperthyroidism. So we have to find out the cause, and sometimes you find out a nodule or a Graves' disease, whatever it is. I think you explain the treatment is going to be, if it is a nodule and everything, whether functioning nodule, whether you want to do a radioiodine treatment or a surgery, whatever is a definitive treatment you plan for a long time, then you can do it. I'll come to that in a minute. But I think these are the things that normally you need to explain in a way about thionamides, complications, side effects, and everything. But you don't need to go into all the details. You have, but nowadays with litigation and everything, you have to explain most of the thing. But just try to be making sure they are comfortable and they are with you, and you say that you're going to be with them throughout the journey, and we are going to work as a team. So this is one of the ways that hyperthyroidism is being dealt. And if it is a low risk, then you continue. But if it is a very high risk, then whether there is any definitive treatment possible, then you do it. So what you say is the PTU is during preconception is the right way to do, and the early pregnancy, as we know, and later stages, if you want, you can add on methimazole and thionamide group of drugs. So radioactive iodine, I mentioned about that. So if you planning a pregnancy, then you have to convince the patients, mostly saying that 6 months later, only after the treatment, then you can get pregnant, sort of thing. And so if you want to do a definitive treatment before that, that will be a wonderful proper scientific way to explain to them. So okay, just get a definitive treatment, leave 6 months, and get the pregnancy going with that. So this can be explained in a nice way. But main thing is just to avoid pregnancy after the 6 months. And I've spoken about the diabetes and thyroid disease as the preconception care, but one of the epidemic that is coming out, if there is quite a few obstetricians are there in our meeting now, we know that obesity is one of the rising challenges that happens, and it is a real disaster for obstetrician for handling them, because pregnancy comes with a lot of sedentary thing in mostly in India, with a lot of people making them to be in the comfort zone, and then that comes with lack of exercise and other things. But these are the counseling that has to happen. But they normally with the obesity, there will be other disorders as well. So you have to take everything into consideration. And then what happens is, the one way I counsel them is that saying that the babies also will get into trouble. So if you look at the genetic predisposition, pregnancy, obesity, and insulin resistance that lead to childhood obesity, and then the newborn getting a cardio metabolic susceptibility, that needs to be explained, and that will convince most of them to reduce weight before getting into pregnancy. Now, another endocrine disorders with the I'll just go through with the prolactin. But it's a 28-year-old female referred to endocrinology with amenorrhea associated with galactoria. The pregnancy test was positive 2 days ago. MRI showed about 9 millimeter in size, and prolactin found to be high, which can happen in the pregnancy as well. But what is the recommended line of management? I think the pituitary disorders are very uncommon in pregnancy, but some disorders like lymphocytic hypophysitis and other things happens only in pregnancy, pre and post-pregnancy state. Not only, but I think mostly happens during pregnancy. So prolactinomas and Cushing's and acromegaly, I'll just go through very briefly about it. So microprolactinoma is less than 10 mm and macro is more than 10 mm. So if you explain that the pituitary undergoes changes anyway in pregnancy that can make the uh, global hyperplasia due to estrogen level, that can lead to visual theoretically, but it can happen as well. So but microadenoma of less than 10 millimeter is rarely a problem in pregnancy that we need to convince the patient. And also macro larger 10 millimeter requires very, very improved attention. So it depends on the adenoma size, and maintaining prolactinoma away from optic chiasm should be the challenge. That doesn't mean that we have to do MRIs very frequently, but if you can have a chance, if it's a macro one, if there is a possibility, then transphenol surgery will be the way forward. But the drugs like dopamine agonist, you can consider bromocriptine and cabergoline is preferred during pregnancy. Both acts very well actually. And then if they are pregnant, if they are have got the prolactinoma, they get pregnant, and if it's a very small one, you can stop it and see. But if they are a big one, then consider continuing during pregnancy. But other than that, I think you can do this is one of the ways to do it, but individual cases has to be dealt to along with a multidisciplinary team with a gynecologist. So again, just to say that we have to screen for the pituitary disorder in the preconception if there is a suspicion. Hypoc, normally induction of ovulation, you do it. And we have to, if there is a pituitary disease, monitoring the T4 level, free T4 level will be useful. And the growth hormone secreting acromegaly and other things should be treated before getting pregnant. But I think going into the bone area, this I will just touch base on it. So, like for example, osteoporosis, pregnancy-induced osteoporosis, and cumulative length of breastfeeding and multigravida. These are all the past histories that has to be taken properly, and nutritional history should evaluate about the calcium and vitamin D deficiency. And hypoparathyroid women should continue the calcium and vitamin D supplement. And we have to make sure if you do a PTH level, that can vary during pregnancy, and it may not be a reliable marker. We should just keep that in mind when we do the test actually. How about the adrenal disease? So adrenal disease like FIO and Cushing's and Addison's all must be, we should initiate the treatment before. And if you can deal with FIO and Cushing's and other things just before pregnancy, that will be ideal. And for example, the CAH must be offered a genetic counseling and preconception care. But when it goes to specialized endocrine field, like what I was just talking about, like a pituitary and parathyroid and adrenal, it has to be the individual patient basis. We have to do the counseling, and it has to be a teamwork with a gynecologist and other intervention. For example, if it is a neurosurgeon or whatever, so we need to deal with as a team. But again, Addisonian patients, hydrocortisone instead of prednisolone or dexamethasone should be preferred. If you want to use prednisolone, by all means, you can use if hydrocortisone is not available. And patient needing a mineralocorticoid replacement, maybe using fludrocortisone is a possibility, but it's a category C drug during preconception or early pregnancy. So it is very difficult to conclude about the need for glucocorticoid therapy in non-classical CAH, but it is the benefit is not that much actually. But if you have a history of infertility or abortion, you might as well use it. So pre-pregnancy dose of glucocorticoid should be continued. The stress dose of glucocorticoid should be used during intercurrent illness. If there is a diarrhea or any other illness comes in pregnancy, then that can be used with a high dosage. But DHA is not indicated, and anti-androgen therapy should be discontinued. How about PCOS? PCOS, I think that's one of the other common endocrine things. It should be counseled, patients should be counseled for continual lifestyle therapy and diet and exercise to achieve weight loss. That has to be there. And if there is a drugs there we given for PCOS, except metformin, everything should be discontinued. Orlistat or liraglutide for weight, or if you given any hormonal contraceptives, that has to be stopped. But the local therapy like laser and epidural treatment can be continued, but most of them will like to not have that one as well. But the other drugs like spironolactone, finasteride, and completely no go, and it is should be stopped even before. So it has to be shared decision, as I said, and before preconception, counsel, and get the patient in your side before getting the pregnancy confirmed. So what I've done in the past 15 to 20 minutes or so is just mention about the common endocrine conditions like diabetes,
Make
which
her.
can you mute others, please? So for diabetes, it is important the patient education, and also as a team we have to approach and you explain about the risk that involves in type 2 diabetic patients, and how well we should monitor the blood sugars and other things. That has to be explained very clearly to the patient. And then about the treatment that we are planning to do, we plan to do in pregnancy will be metformin along with some insulin types. Normally it's a basal insulin or bolus insulin. Go through all that as a preconception care. So that is the main thing in diabetes management. And thyroid management, if you got a hypothyroid patient, is simple that you say that it is going to be the drugs what we are continuing during pre-pregnancy one. Make sure that the doses are adequate to reach the TSH below 2.5, and other nutritional things like B12, vitamin D, all are corrected before preconception, and also maintain the level. How frequently we should make sure once patient is pregnant, just give an idea how frequently they should come for your follow-up. And about hyperthyroidism, patients start on the drugs which is more friendly, like a PTU for the early pregnancy and preconception care. And the later half of the pregnancy, you can go for thiamide group of drugs. And if you can able to treat completely with radioiodine or surgery, whatever, then you do give a 6 months gap, and then go for the definitive go for the pregnancy. And how about subclinical hypo? Again, just consider all the family history and whole lot, and antibodies and previous pregnancy and other
Shyam,
things.
sorry, but we are half an hour, and I know it's a Sunday, so I will have to ask you to wind up. Thank you.
Sure. And so it has to be unique, and hence the decision of as a team matters a lot. Thank you so much.